From the JAMA Network, this is JAMA Internal Medicine Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Internal Medicine.
Hello and welcome. This is Dr. Louise Aronson, online editor at JAMA Internal Medicine. Today we've got a double header for you. 2 authors, 2 articles, and 1 powerful discussion of a topic of critical importance not just to healthcare but to American society: harm to unarmed Black persons by law enforcement. In an excellent editor's note accompanying these articles, my colleagues Giselle Corby, Reagan Durant, and Mitchell Katz provide the impetus for this month's podcast. They write, "While we have focused over the last decade on the social impact of the high-profile police killings of George Floyd and multiple other unarmed Black individuals in the United States, the health effects of both fatal and non-fatal police violence on Black populations need to be documented as a critical first step to reduce these harms." The 2 articles we are discussing today do just that. Our guests are Atheendar S. Venkataramani, MD, PhD, the lead author of the article Officer-Involved Killings of Unarmed Black People and Racial Disparities in Sleep Health. Dr. Venkataramani is a general internist from the Department of Medical Ethics and Health Policy and the Leonard Davis Institute of Health Economics, both at the University of Pennsylvania, where he also runs the Opportunity for Health Lab. Our second guest is Kevin N. Griffith, PhD, author of Injuries Due to U.S. Legal Interventions Involving Conducted Energy Devices. He is a health services researcher from the Department of Health Policy at Vanderbilt University Medical Center and also the Partnered Evidence-Based Policy Resource Center at the VA Boston Healthcare System. A warm welcome to you both to the JAMA Internal Medicine podcast.
Thank you.
Thanks for having us.
So I'm going to start with you, Athene. Why did you do this study?
Yeah, thank you so much for having me on to talk about our team's work. The impetus for our study starts with one simple fact, which is that sleep health is an incredibly important piece of health in and of itself, but also a driver of mental and physical health in general. And there's increasing attention being paid on the determinants of sleep health. What we do know is that on average in the population, sleep health is worse among Black Americans than among non-Hispanic white Americans. It's been posited that this is because of systemic racism and other structural factors that create unequal opportunities for Black individuals in ways that harm their sleep as well as their physical and mental health going forward. So that was really what we wanted to look at. We wanted to complement the literature, of which there's now a growing amount that we're trying to build on, by trying to really understand the cause and effect between systemic racism and sleep health outcomes. To do so requires a model system, just like you might do in a basic science paper. And so for that, we looked at police killings of unarmed Black individuals. This is the subject, as you mentioned, of a national conversation about disparities in exposure to policing. The killing of an unarmed Black individual invokes a sense of injustice and unfairness that speaks to the systemic drivers of unequal opportunities between these 2 groups of Americans. And so we focus on the episodic nature of those killings and how individuals living in areas where these killings occur and through various channels might become aware of them, how their sleep health evolves as a result of being exposed through those various channels to these particular events. In doing so, we're trying to lay out a methodological contribution, which is really to say, here are the different ways you can measure exposure. Here's the ways that we're measuring the outcome. Here are population-based surveys that collect this information. Let's try to put that together and see if we can really understand these causal relationships in ways that both speak to the spillover consequences of police officer-involved killings, as well as potentially the other structural drivers of health that we know are operative in the Black population.
Wow. So it sounds like in terms of focus, we know sleep is critical for health. So you're looking at new ways sleep might be disrupted and, lower quality in Black populations. And you develop a model to help us find other determinants of disparities, which clearly is much needed. So that's fantastic. Can you tell us a little more specifically about how you went about this study and what your findings were?
Sure thing. So the fact that we start with is that people who are surveyed in the Behavioral Risk Factor Surveillance Study and the American Time Use Survey provide information about their sleep over a period of time. These measures are different, but they generally tend to track with some of the types of measures you'd get in a laboratory. And so the timing of when people are interviewed in these surveys is effectively random. The sampling of these surveys is based on random digit dialing. And so we leverage the fact that the random timing of the survey is effectively random in general, but also random relative to the occurrence of a police killing in the state of residence, in the county of residence, or nationally. And so we use that fact to set up a quasi-experimental research design to say, if you were exposed to police killings in the 3 months, 3 to 6 months, 6 to 9 months, 9 to 12 months before your time of interview, how does that affect the sleep duration that you report at a particular time during interview? So that's the basic general setup. And the intuition is that surveys are done at random times, and relative to world events, they are random. And so we can use that fact to try and understand cause and effect.
Awesome. And so the findings were?
Sure. So we found that within the first 0 to 90 days and 91 to 180 days, we see a strong association between the occurrence of police killing, whether it's in the state of residence or nationally. We see a strong association between that and the reports of poorer sleep, particularly the tails of distribution. So if you look at short sleep, which is defined less than 7 hours, or very short sleep, which is defined less than 6 hours, that's where you see these police killings of unarmed Black individuals tend to have these negative effects on sleep. This is only true in the Black population, and it has specificity to the killing of unarmed individuals, which we know is uniquely taken as an indication of injustice and unfairness. And so that's what we find. The estimates are for something that is an episodic, though unfortunately frequently occurring event. We find that the estimate sizes that we get are about anywhere from 7 to 15% of the overall Black-white disparity in these sleep duration measures. So that's not trivial, and especially given that it's a time-limited exposure in some ways. And it's an order of magnitude lower than the association, say, between shift work, which Black workers tend to be more exposed to, and sleep health or something like that. But these are material consequences. They're occurring every day. They're part of the thousands of paper cuts that this population faces that over time weathers their health in profound ways.
Right. I was just thinking something similar about, 15% here, 7% there, and it all really begins to add up and make a difference. And I feel like this is also helpful in contributing to those studies which show that even for Black populations who are, living with some of the privileges that more commonly accrue to white people, we still see this earlier morbidity. And this would be one possible explanation for that. So thank you for explaining your work. I'm going to turn now to you, Kevin. And can you tell us what brought you to the work that resulted in your research letter on injuries due to U.S. legal interventions involving conducted energy devices?
Absolutely. Yeah. So we're, as Atheen mentioned, we're in the middle of this national conversation about policing in America, and especially about police use of force. There's debate about when police should use force, the types of force they should use, whether their training protocols adequately encourage de-escalation, whether the best choice to respond to mental health emergencies. However, there's an information famine for policing in the U.S., right? State and federal governments, they track cases of food poisoning, injuries and deaths from children's toys, the number of people that hurt themselves falling off ladders. But if we want data on injuries due to law enforcement encounters, we are on our own. So a number of researchers and organizations, they've done yeoman's work, crowdsourcing data on officer-involved killings from media reports and other sources.
Can I just jump in here?
Yeah, absolutely.
Sorry, I hate to interrupt, but I think we just have to emphasize that your results may show some disparities, but the fact that we gather data on people falling off ladders, but not harmed by law enforcement, I just felt like that needed like an extra beat. I'm so sorry to interrupt.
Yeah, absolutely. I remember when I first encountered this, it's just a wild thing, what the government chooses to officially track and what we choose not to report. Beyond firearms, conducted energy devices, of which people sort of recognize them as tasers, which is the most common brand, they're seen as like this attractive, less lethal option than firearms, but the data are even harder to come by. We can look at injury patterns for CED, I'm going to call them CEDs for short. We can look at data in European countries that collect it, but not here, at least until now. So we can start to scratch the surface of this. So in our study, we have this novel data, and our objectives are kind of inform this national conversation on U.S. policing tactics by providing data on how often people are sent to the emergency room due to law enforcement use of tasers, the types of injuries they present with at the ED, and whether these injury patterns vary by race, ethnicity, and the area income for where you live.
Great. So can you tell us what you did?
Yeah, so first we obtained data from a system called the Nationwide Emergency Department Sample for 2019 and 2020. It has data on about 28 million ED visits per year, and it includes weight, so you can make nationally representative estimates with it. And then there's a brand new ICD-10 code that was introduced in late 2019 that includes CED use by law enforcement. So prior to 2019, these injuries were all sort of lumped together under one generic ICD code. We couldn't differentiate injuries to police action versus an individual using one in self-defense. But now we can. So we looked at ED visits with this code, sort of cataloged the types of injuries, created measures of injury severity. So we had this thing called the abbreviated injuries scale, which is called the AIS. It grades injuries for 6 different body regions from minor to something serious and life-threatening. And then we calculated this overall measure of injury. It's called the new injury severity score. And this takes your 3 most severe injuries that are on the record, grades them from a scale 1 to 75, with 75 being unlikely to survive.
Wow.
And then we looked at whether these patterns differed by race, ethnicity, and also income.
Right. And what did you find?
So we found just under 1,300 ED visits in our data with this code, which is not bad for the first year or so of a new code being introduced. So after waiting for national representatives, it's about just over 5,000 ED visits for taser injuries by law enforcement. A majority of these visits involved young white and black men from low-income areas. The black individuals were very overrepresented in our sample relative to the U.S. population, sort of matches our previous research suggesting an increased risk of police interactions and injuries among black communities. And then a decent proportion of the ED visits didn't have any injuries recorded, so people were sort of checked out and allowed to leave. But for those with injuries, about 60% were minor, just over a quarter were moderate, and the remaining about 15% were serious to critical injuries, including 2 individuals who died. So these injuries were varied. They include puncture wounds, foreign bodies related to the barbs from the taser itself, the lacerations, but also a lot of people had concussions, fractures, traumatic brain injuries, which I believe is due to when you get hit with a taser, you sort of have this loss of neuromuscular control, you fall to the ground, and then you could hit something on the way down. We also noted with some concern that the bulk of these injuries were sort of to the chest, lower abdomen, to extremities, but just under a quarter of them were to the head and neck, including to the face. We saw records where people were showing up with barbs still attached to their face.
So the barb can come out of the taser?
Yes, a lot of times, yeah. Yep, the bars come out of the taser, and then they're detached from the device, and so it's not uncommon to show up to the ED with the barb still embedded in the patient. So we saw these, which tells us that perhaps additional training might be needed on proper barb placement, avoiding sensitive areas. And last, we looked at the injury severity by race and ethnicity. We did see some differences. We saw Native Americans tended to present with the most severe injuries. Asian Americans tended to present with the least severe. These differences weren't large enough to be statistically significant, possibly just, it's a new code. We don't really have a huge sample yet. But what was statistically significant was these differences in injury severity by household income. So we looked at patients that lived in neighborhoods with incomes above the national average compared to patients who lived in neighborhoods with incomes below the national average. And those below tended to present with more serious injuries. So we did see an income gradient in the severity.
Wow. So all kinds of, conclusions one should look into, I suppose. Conclusions one could jump to, but should probably be studied. Terrific. So I have about 1 million questions for both of you, but incredibly, we are already a little over our time. So what I'd like to do is sort of quick fire rounds here of if you could say one thing about next steps for your work, really briefly, Atheen, what would it be?
For the research itself, I think it's trying to bring in other exposures that we think are related to systemic discrimination, or just across a large set of populations, not just Black Americans, and try to bring them into an empirical framework where we can study their effects and understand when they're relevant and what might moderate them. That will be really useful for trying to design interventions.
Absolutely, to decrease disparities. And Kevin, your next steps?
Gosh, I think for this, you're trying to build out the data to sort of inform this national conversation. We now can see people when they show up to the ED. We still, there's a lot of methods work trying to find out like what's the burden of injury due to people that just get treated on site and go home, or that might go to urgent care or some other care setting. So we think that while we're showing these injuries, we're probably still dramatically underreporting the number of injuries due to tasers, and that's something we need to work on.
Yeah. I think one of the things I love about both these papers is that, it sort of addresses the issue of you don't see what you don't look for in terms of what data you're collecting and also what you're putting together as associations. And these both feel like huge progress to me. So thank you both for your work. Before we sign off, though, we really want these podcasts to be useful. So I wonder if each of you could throw out a practical application or a clinical pearl for clinicians from this work. I mean, a lot of good ideas for researchers already, but how can we as clinicians maybe apply the work? And let's start with Kevin this time.
As I mentioned previously, the data on taser injuries aren't tracked by state and federal governments. Thus, up to emergency medicine docs and health systems, they play a critical role in making sure we have the right data to conduct this research and sort of inform the conversation. So it's a new ICD-10 code for injuries due to law enforcement use of conducted energy devices. It's likely underutilized. So I'd love to see physicians have greater awareness and utilization of this code so that we have better data.
Yeah. I wonder about for internists who aren't in the ER setting, also like just outpatient docs. You see an injury, you see a thing, ask, code, follow up, etc. Awesome. And Atheen, your pearl or practical application?
We screen for sleep disorders in the internal medicine setting. One of the things that might be interesting is to try and ask the next question, which is, why do you think it might be happening? We often go straight to thinking about OSA or obstructive sleep apnea or something like that. But might there be something in the social world that affects sleep? And it could be related to police killings. It could be related to how we feel about inflation. But there are lots of these stressors that are out there that I think people are responding to in ways that are in the short run and maybe in the long run harmful for their health. And while clinically we don't have that kind of structure to be able to intervene on those macro determinants of health, being aware of them and potentially pointing people in the right direction for counseling or other resources could be really, really useful in the short run as we try to figure out how medicine intersects with society going forward. That's a bigger conversation, maybe next time.
Absolutely. But, building those blocks. So thank you both so much for being here. This is Dr. Louise Aronson, online editor at JAMA Internal Medicine. We hope you've enjoyed this JAMA IM podcast. This episode was produced by the wonderful Daniel Musisi at JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. And thank you for listening.